avoiding someone with phobia, which is called one. Avoiding someone with it to enter river. They don't always allow anybody that has phobia. They will not allow person to enter river. They believe if they allow the person to enter river, it can spread the disease. So all these are been a measure before the advent of the modern medicine. So talking about chickenpox among this particular set of people, they believe that there is a spirit behind sharing chickenpox, and chickenpox and smallpox. They categorize it into the same thing among them. Yes, among the Yoruba, they categorize chickenpox and smallpox to be just known. So they either call it shokono. So it's popularly known as shokono, while some part of Yoruba refer to it as igbono. So among them, they believe that there's a spirit that is working at one particular hour of the day that is sharing this disease, which is not in line with modern medicine. So what we know that is in line with modern medicine in this aspect is the things that can come out of someone that is going through this particular disease. What are the things that can happen to the person? The first thing that can happen to the person that can cause blindness, and this is also in relation to what is stated in the WHO, World Health Organization, about the effects of smallpox. So this particular disease among the Yoruba, I've said it earlier on that they believe the spirit that is sharing it in a particular hour of the day. That is why when it's around 1 to 3 p.m., they call people in walking around. They'll say, Igono, Igono is outside. So you should mind the way you walk at that particular hour of the day. So they believe if such thing visits a person, if the person is trying, in as much the person is just trying to deviate from fashion. If you have measles or you have a chickenpox or smallpox, in that period of time, they will tell the person not to be using any fashionable something that Papa Wakiomo, that the spirit just came to visit and is going to go at any time. If the person adheres to all those things that is required for the person to do. So, and also another thing they do in order to share the spirit is the using of very akoko is a leaf among the Yoruba. They always hang it at the entrance of the door in order to shade the spirits for not entering their house. So all these things are what they use in order to prevent the spread of any communicable diseases among them. What is just common between modern medicine and traditional way of precautions among them, the common thing is just the cleanliness and the use of precautions like vaccine that is related to the modern medicine. Why the Yoruba people they make use of ogunle tutu? So that one is just they believe is an antidote that can cure many other things. Even if they don't have anything, they will give their children the ogunle tutu so that they will not have any kind of communicable diseases. They believe that the ogunle tutu will build their immune system and make them stronger in order not to contact any diseases. So those are the things, those are the ways they use in preventing diseases, the spread of diseases among them in the olden days. So the intersection that we have there, the major one is that cleanliness. It's common and it's one of the things that is stated in all the regulatory bodies that is controlling communicable diseases. They all also preach cleanliness, which is the basic thing that Yoruba always do, is within them and they always adhere to it. So the second one is the use of vaccine. While Yoruba people make use of ogun electricity. Findings. This article comes up with the following findings. Yoruba cleanliness precautions of communicable disease capture many precautions of communicable diseases as stated by WHO and NCDC. The intuitive knowledge of Yoruba on isolation is an interesting one that the application helps the spread of communicable diseases such as COVID-19, Ebola, and others. They also make use of isolation too. Then the restriction of movement between some hour of today also is one of the things that we see in modern medicine when there is outbreak of COVID-19. The ethics and belief attached to dead body of COVID-19 patient is not new among the Yoruba. They have the intuitive knowledge that the dead body of a patient of communicable disease is also contaminated. So the Yoruba intuitive knowledge on blindness, effect of shokono, which is chickenpox or smallpox, correlate with the effect of smallpox as stated by WHO. Self-isolation or isolation of patients of any communicable disease does not mean, as I've said earlier, does not mean that they take the person or the victim, just that the society is trying to take responsibility of protecting other members of the community. Thank you.
Thank you, Marcella, for the presentation. We will now go to the next presenter. Is Sandra ready? Is Sandra ready? Controller?
No, I don't. I'm not sure she's ready.
Yeah. So we go to Chinela. Chinela, who is presenting on the topic man of patriarchy and men's mental health in 21st century society.
Good afternoon, everyone. My name is Chinela Dako, and my study is focused on most of my study is man of patriarchy and men's mental health in 21st century society. The study will explore the interplay between patriarchy, men's mental health, and public health through the lenses of the phrase man of. To examine the relationship between conformity to traditional gender norms and psychological distress for men in 21st century. To also identify public health challenges posed by untreated mental illnesses and emotional suppression. For us to understand this, we need to understand the concept or the angle I'm coming from. When you talk of man up, you're looking at the gender's command promoting emotional toughness. For example, you hear someone tell you, guy, be brave, man up. Like when you are having some issues and you don't know how to express yourself, someone say, you're a man now, man up as a man. So actually, looking at the cultural practice rooted in traditional leadership that promotes male dominance, emotional control, and performance of strength. In Igbo land, we see men, when you're a man, you should be strong. You have this strength that have been bestowed on you before you even get to you because you are a man. So this patriarchy, we're looking at how if you are talking about patriarchy, is it really okay for men? Is it okay for yes, they are benefiting from it, but are there any side effects of patriarchy? That's what we're looking at. Then mental health is a form of protecting emotional, psychological well-being. When someone is able to do things or communicate well, work well, or is productive, we'll say the person is mentally okay. But when someone is not mentally stable, you know that there are some issues that the person cannot do or things that the person cannot do. Public health here is focused on prolonging life, preventing diseases, and promoting health through organized effort of the society. Research questions. What's the relationship between the phrase man up and men's mental health in the 21st century society? They're asking you to man up. Is it affecting your mental health or is it not affecting your mental health? Is there any consequences that comes with manning up as an individual? How has conforming to traditional gender roles led to psychological distress amongst men in the 21st century? Patriarchy as the cultural phenomenon has been on from time being, and how has this conforming to this traditional role of patriarchy led to psychological distress? This conforming to this traditional role led to psychological distress in the past. Our fathers and influenced patriarchy when they were during their time and they are conforming to this traditional role, it affect them psychologically. You know what has changed and why is it affecting men now or is it not affecting men now? And then how is it affecting public health? Is it causing issues for men or not, and the public? So cultural codes and expression of masculinity in Igbo society. You hear of proverbs like "Okana Ebakwa" or "Agunwoke," or you hear "Nabunwoke," like "Okana Ebakwa," like men don't cry. "Agunwoke," you're a lion, you're strong, and maybe you hear something like "Okay, bro, okay, guy, be a man." That is manhood. Then traditional roles, you have roles that are reserved for men because he's a man. He should do things that are hard because he's a man. He should always provide because he's a man. If the woman is working and the man is not working at that point in time, so as a guy now, you're a man and you are still at home. You know that all of us are human beings, and sometimes it might be problem for that man at that point in time. So but because the man might not want to thought, oh, you're a man, what are you doing? He might want to do some other things that might not be okay for him and for the society. Societal expectations. We expect the man to do so many things for us. And then if a man does not meet up to those responsibilities because the men that made mistake, they failed, or we see them as being weak. Seeing them as being weak, is it affecting their mental health? Or because the man does not want to be seen as being weak, is it going to affect his mental health? And maybe he goes on doing things that might not be okay for him. So these are the cultural codes and the various ways men would experience their things in Igbo society. Then we want to look at the impact of patriarchy on men's mental health. Because you're a man, you are meant to suppress your emotions. You might not cry. You lost someone and you cannot cry out, say, I lost my child, I lost my mom, I lost my dad. Are meant to be strong. Be strong for the family. You're a man, be strong for the family. And the other person that is a woman will also be strong, or the child might also be strong for the family, but because he's a man, he's not meant to cry. So you're pretty pressured to suppress that emotion in the sense of man up. So patriarchy is just telling us to man up. And as you're suppressing your emotions, it can lead to anxiety, can lead to anger, can lead to depression. And once once you've gotten this level, you start behaving some way that's not good for your family, that is not good for the public. You can go into taking drugs that you're not supposed to take, or you can start going out to hang out with people that you're not supposed to hang out with. And then you are being excluded from your family. You are living in the isolation and you are on your own. So being pressured to suppress your emotions, you're always angry. You could go into domestic violence, beating up your wife, beating up your children, and then when you want to recover, it could lead to death. This is against our aim of public, like prolonging health in the public, life in the public. And then once they are sick, you see someone that is sick, you know that truly, like you are depressed. You cannot speak up because once you speak up, be like you're a man. How can you say that you are depressed? Depression is meant for women. So because we can be like you're a woman now, being depressed is okay. Because they always try to always say that being depressed is okay for the woman, but as a man, you're not supposed to be depressed. So once you have this mental health stigma, you cannot bring up people to tell them still I'm passing through, or they're asked to go to the hospital, you cannot go to the hospital. And you carrying it means another thing because you won't be treated early and you won't find solutions to your issues. Then neglect of physical health. You might be sick, really sick, but to go to the hospital is an issue because you are trying to man up. Maybe you are trying to save up for the family, or maybe you are trying to not to go out and disgrace yourself, or maybe you don't want people to look at you somehow. You are trying to man up, so you are neglecting your physical health. It could lead to unhealthy coping mechanisms like substance abuse, violence, obesity. You keep eating things, or just to make sure that you are finding yourself in a way that just for you to leave your mind instead of picking up someone or telling someone something, or you're in a violent marriage and you cannot speak up because you're a man. So people will not laugh at you and say, so you're a man and this woman is dealing with you like this. So during the course of my interview, I met from a woman, I met some other people that I just recruited to today. He said, I've not seen my husband today. He woke up one morning and left. I only heard from his friend that he was tired of seeing his children go to bed hungry. This lady, Mrs. Neka, when she's a hairdresser, she had 7 kids. So till today, it's like the 7th year, she has not seen her husband. Was man's friend that was telling her that your husband, man, ran away. Because he could not, maybe he was seeing himself as a failure, or that he was seeing himself as, because he said that every man should do something. And he was not doing something at that time. Everyone saw him as being weak. So the man ran for his life. Until today, we have not seen him. And the woman herself, she's not finding it easy. Her children are causing issues with the child. The one, oh, God, they caught one. She went to pick up this, something to transformer. Because maybe they don't have anything to eat and something like that. So maybe that guy had gone there and died on that thing. So not until I became a drunkard. Because my wife and children at some point, I lost a lot of friends who have shared not the person I have become. Today, my children see my wife as their hero after my years of sorrow. He's lamenting that today, because that is, the children don't see him as anything, like, not amounted to anything, because that maybe he was not providing for the family as it should. So psychologically, this man is not okay. He's down, mentally he's down, because society believes that all of us the men should man up and carry out their responsibility. In conclusion, the paper is not advocating for men to drop their attacks to masculine ideas. We're not asking the men to please stop being men, or stop being our fathers, or stop being the head of the family, or stop doing what they're supposed to do. We're only asking them that you should be flexible. Like, if you're having problems, you could relate to somebody. That is an issue that I'm having. Yeah, let people there for you. Because that's all that. When you embark on your journey of strength, I know you are strong. I know you are strong, and you still flexible, but still embarking on your journey of strength. That's manning up. Sometimes just losing up and try to speak to people. So the fact that if you want to a family or community based and media informed intervention on mental health, because sometimes we don't really talk about it. So once we keep talking about it, and from the family level, we talk to our fathers, we talk to our children, when we give birth, we start telling them, you're a man, you're this man, do this one. So we just try to propose this intervention from the family level to the community level. And then we have the social media. We control this list also. Let the men speak up. If you're having issues, please, we can intervene. Everybody cannot just say, because I'm a man, I cannot speak, and then you are causing problems for yourself and for the public. So for us to look at public health, or to look at how we can prolong our lives, or to look at how we can manage ourselves, we also need to pick up this issue of manning up beyond going to the clinic and other things. Thank you.
Sorry.
This I think we are going to have a lot to talk about, because this paper has been presented by a woman, and it speaks to a very important conversation that a lot of men recently are having now. And I'm particularly curious to know how people will respond to this. But I think it would have even been even more interesting to hear the voice of the participants, apart from the two that you read. It would have been really enriching for us to learn how men are thinking about this issue. But thank you so much for sharing this very important work. I want to find out from Sandra whether we can get to our work now.
Yes, Sandra is ready.
Okay, great.
Yes, yes.
Okay, please enable my share so I can share.
Okay.
Is it enabled now?
It's not enabled yet. You can click on
Okay.
the share button.
So you can start while he works on that.
Click on the share
I
button.
can't share. I can't share. Okay. Okay.
You can share now. What's you
Click on
doing?
the share button.
Okay.
Yes, I'm here. I'm here, sir.
Yeah.
Before you continue,
Okay.
Sandra, Candy, in a few seconds, please. We have our final presenter
Okay.
as well. And
Okay.
a question of mostly you, Olorun Shola Sonny from Kwara State University. We are going to have your presentation in a couple of minutes, but please hang in there. So now, Sandra Nkechi is going to be talking about beyond the clinic, alternative medicine among ICA people of Delta State. So you have 12 minutes to present.
Okay. Good day, everyone. I am Iwerilo Sandra from University of Delta, Agbo. I'm talking on the topic Beyond the Clinic, Alternative Medicine Among ICA People in Delta State. Introduction. Now, despite the influence of medical, can you hear me? Despite the influence of medical system, traditional medicine enjoy huge patronage from, oh God. Please, I'm sorry.
I'm still.
All right. Despite the influence of medical system, traditional medicine patronage and support, many people still support the patronage of traditional medicine. Traditional healing practices are guided by cultural specific understandings of disease etiology, which often diverge from biomedical perspectives. Traditional medicine plays a critical role in healthcare across Africa, especially among communities like ICA people of Delta State, Nigeria. Now, these divergences are mostly rooted in historical tensions from colonial influences that marginalize indigenous knowledge and healing systems. Now, for instance, illnesses are frequently attributed to spiritual forces such as ancestral displeasure or witchcraft, which can delay biomedical seeking and complicate early efforts to manage infectious diseases like malaria, tuberculosis, diabetes, and sexually transmitted infection. Oh, good. Now, given the diverse mechanism by which pathogenic microorganisms proliferate and spread within different body tissues, accurate diagnosis and standard adherence is paramount. Now, this study aims to explore how ICA people use and reflect broader concerns such as preserving traditions, ensuring equitable access to preserving cultural traditions, ensuring equitable access to healthcare, and ethical integration of traditional medicine into public health systems. Now, this methodology, the study design is a mixed method. Cross-sectional study was adopted. Now, the study area is ICA Delta States, that's rural and peri-urban communities of ICA in Delta State, Nigeria. Now, the study population is 18 years and above who currently use or have used Agbo for healthcare purposes. The components as is stratified random was ensured to use demographic representation, which are gender, age, and education. Also, the analysis used or data analysis were conducted using statistical packages for social sciences. Now, the results are, now in this study, we had 4 decision means. We had 4 decision means, which are 1.5, 2.0, 2.5, and 3.5. Since the instrument was structured along different responses, patterns to decide on whether to accept or reject questions after comparison with the mean. If the mean is greater or equal to decision mean, the score indicates a positive mean. We accept or agree with the research question. Now, the results. During the survey, surveys were given to respondents, and these are the distributions of the outcome of people who use Agbo in this peri-urban area, which is the ICA communities. Now, among the age distribution, we have 15 to 19 years, 20 to 24 years. Now, if we look very well, we find out that the age 40 to 44 has a very good number of percentage of
Sandra.
Uh,
Can't, okay. I think it's a network.
This age group, can you hear me, sir?
Yes, we can hear you.
Can you hear me?
We can hear you.
Okay.
Continue.
Now, from this 40, okay, all right. From 40 to 54 years, you see that these people has the highest number of percentage of people who use this agbo. And we see that from this age, these people are middle-aged people who are likely to be decision makers of healthcare and decision makers in their families. If you check from 15 to 20 to 19 years, they are younger adults who use agbo. And this shows that number, or the minor number simply shows that there is
I think we are
traditional medicine to biomedical options to this.
I can hear you from this place.
Okay.
I'll be talking on.
Can you hear me, please? Okay. Can I continue?
Hello, Sandra.
Continue.
I think
Can I continue?
We're having serious difficulty.
Yes, I can hear you.
Okay, please continue.
Okay, all right. Table 2, option of respondent level of education. Like I was saying, if we go through this table, we find that at the tertiary have the highest number of people who have tertiary education, amounting to 76.7%. This simply goes to show that if it doesn't diverge them from taking agbo, they still take agbo even with their level of education. They take. This will negate the assumption that traditional medicine is always taken by people who are less educated or not educated and the poor in rural. Now, we go to option of responding by gender. You find that the gender is a near equal gender, which means that everyone, both male and female, participates in the use of traditional medicine. Table 4, the son of respondent by occupation. Charts, you find out that civil servants are higher, which is that persons, they have stable employment, but still use traditional medicine. So because of traditional.
Sandra, if you can, please kindly get to the conclusion really fast, because I think we're having serious internet issues.
Okay, you can see people who have used it. Many people claim they don't know anything about antimicrobial resistance, even though it's there, and some of them have admitted to the fact that they take both orthodox medicine and the traditional medicine, knowing the implications. There could be drug interaction and reaction, which they may not be aware of. So discussion. Despite cultural significance, respondents report low frequency of agbo use and limited knowledge about this preparation and dosage, suggesting a shift towards biomedical healthcare or reluctance to disclose their traditional medicine use. Now, I want to acknowledge the Agbo's effectiveness, skeptical about its safety compared to orthodox medicine. Combining Agbo with medical treatment is common, though the potential risk and side effects are recognized by and low support for government regulation, highlighting critical gaps. I'm concluding, please. There is no doubt that the use of Agbo. Can you hear me?
I hear you.
Can you hear me?
Yes, we can hear you. So the internet is not favorable. So I think we just
inclusive that the use of Agbo strategies help with thus finding these findings from this study underscore the need for cultural regulation that respects indigenous knowledge while ensuring safety and efficacy. Thank you.
Thank you.
Okay, we get the idea, but hopefully, Sandra will remain online in case there are questions and comments on our presentation. So now go to
Thank you once again, Chairman. I'm presenting something on Baptist Mission medical policies in Yoruba land between 1907 and 1986. A journey of close to 8 decades that I'm trying to interrogate within the Baptist space and medicine. The Baptist mission of Nigeria medical policies were a set of principles or course of actions which were targeted at control, mechanism adopted by the Southern Baptist Convention or the Nigerian Baptist Convention for the smooth run of the medical activities or medical ministry, what we refer to as medical evangelism, in meeting a targeted goal, which captured in preaching, teaching, and healing, and which is described as a triangle. We refer to it as the triangle of the Baptist mission. The colonial and post-colonial era form the periods in which this study is situated in the 21st century. The colonial medical services were solely owned by the state and owned by the government, while the Baptist mission is solely owned by the church. And although at the time there was a kind of collaboration, which will take me to the next slide, and here we'll be talking about looking at it from 1907 to 1960. It was solely controlled and managed by the church. Then between 1960 and 1986, there were engagements of the church and the state. We observed that from 1975, there was a kind of collaboration between the church and the state till 1979. And by 1979 to 1986, the state government of Oyo State then took over from the church, and by 1986, it was restored back to the church, and that was what informed the scope of the study. The Baptist Mission Medical Services started in 1907, and the handing over of it back to the church, which made it a complete circle, was in 1986, and that's why the study is terminated at that spot. The gap in this study is that over time, Baptist mission has been discussed and it has emphasized the aspect of education, the aspect of church planting, the aspect of preaching and all the likes, which form the two sides of the triangle, which made the triangle to be incomplete and an open triangle, or we refer to it as tangent triangle. So, but the coming of medical services made a complete triangle formation, and that is what actually promoted the Baptist mission and made it to have a landmark impact on the communities in Yoruba land. And that is why, and the space or the gap in this study is situated within the 9 selected communities, which some of them are Ogbomoso, Shaki, Ilero, Okaka, Iwo, Oyo, and others. So now it's like bringing this community and trying to interrogate how the policies, medical services were engaged in those locations. The method applied to this study, where I applied the methodology or the source of primary and secondary. The primary sources include or made use of the archival information, oral interview, and diaries of the Baptist mission, not the government archival materials. Then the secondary sources engage books, journals, and internet information. Now, having explained the gap, the method that this study has engaged in, to quickly look at the medical policies which were used or which were found in the period of our study. The first policy that was engaged was the policy of free medical services. This was the first one that was used by the Baptist mission from 1907 to sometime around 1960s, in the 60s, period immediately after independence. So it was totally free. So being free in this perspective is that when the patient goes there for treatment, the medical officers or personnel will attend to the person, because the church from America make provision for all that. Then another policy used in the period of study is concerning how did they engage, how can the medical work be initiated or started in this location. So there was a policy that if we are going to start a medical work in a particular location, there must be need for it. A need must arise for it. It will not just be that you just go and plant a medical infrastructure over there. Another policy of the mission, or Baptist mission in the area of medical services, is that of the triangle, which I mentioned earlier, that when a patient comes around, the patient will be preached to, the patient will be taught, and then the patient will be administered to through the spiritual and the medicine. And then there's also the policy of language, that whosoever is appointed to coordinate or to promote the medical service activities of Baptist mission must have a background knowledge of the language of such community, and which also was enshrined in their activities. Setting up of hospitals was a larger hope of the Baptist medical policy, because the movement of Baptist activities when it comes to delivery of services were in phases. So hospital happened to be the peak of it in the period of study. And here, that's what we refer to as the secondary stage of the delivery of services. We have the ones that are dispensary, welfare centers, and all the likes. There was also a provision of policy for outpatients. There was also provision for policy for inpatients. So if you are coming in for treatment as an inpatient, there are procedures, there are things the person must do. For example, if the person is sick, the hospital will only accommodate the person and one other person, while the person that is sick will only be allotted a bed space. And there will be provision for where they can cook for that person while the person is still going through treatment. There's also policy of ethical policy that treating the patient must be domiciled in attitude of benevolence and helping such patient to recover without being injured. And then if the patient is demanding for a treatment, such patient should not be denied such. So there are other policies like mother-less children home policy, laboratory service policy, medical staff and worker precaution policy, dental clinic policy, location of dispensary policy, expanded programs of immunization, and all the likes. In conclusion, this study has explored the services offered by Baptist Medical Facility in selected communities which are highlighted earlier, and also provided an in-depth explanation on the colonial and post-colonial activities of the Baptist Mission Medical Infrastructure as an independent strategy of the Baptist Mission on the one hand, between 1907 and 1975, 1979, 1985, and 1986 as a collaborative effort between the church and the state, 1975 and 1979 on the other hand. The paper describes the activities of Baptist Mission Medical Evangelism in selected communities by explaining the trajectory of medical policies engaged in the colonial times and in the post-colonial period in the Baptist Mission Medical Evangelism practice in Yoruba. Thank you. As a complete cyclical formation, church to church between 1907 and 1956.
Okay, thank you, Olafemi. I want to confirm if Musli is still alive.
Yeah, it's still
So I can make a presentation very quickly. Yes.
Yes, I'm here. I'm here. Thank you for the opportunity.
You have 12 minutes, please.
You can share your screen. You can share your screen if you have your slide with you. Anything else? Musiliu. I'll share it from the end.
Okay. Did that?
Okay.
I'm here. I'm
Okay,
here.
you're welcome.
Introduction.
Start, please.
In a world where trauma often wears the silent mark of strength, where young people are expected to endure, not express, it becomes urgent to ask what happens when things go unheard, when clinics are too far, and feel too foreign and unaffordable, like the current situation we find ourselves in Nigeria. in southwestern Nigeria, including Oyo, Ogun, Ondo, Osun-Ekiti, and Lagos. Countless youths navigate a daily storm of psychological trauma from economic hardship to communal conflicts, like the recent killings in Benue, among other former harder conflicts, down to cultural pressures. Their mental health is under siege. Yet, despite this growing crisis, access to mental health services remain limited, stigmatized, and deeply disconnected from their realities. Of course, they treat the symptom, not the soul. And you will all agree with me here today that in many Nigerian communities, the soul not only used in silence or through prescribed medication by physicians, but also in reading, in study, in movement, and in theater. This paper, Healing Beyond the Clinic, explores an unconventional yet profound African response. The African response I'm talking about theater therapy to heal the depressed, troubled, and traumatized souls, rooted in music, dance, drama, storytelling. Theater therapy in totality offers more than performance. It offers possibility. It reflects traditional modes of healing and reposition them within modern public health practice. In order to program this study, I used Alien Earthman based research framework. This study investigates how theater can be used as a tool for trauma recovery, emotional resilience, social transformation among youth in southwestern Nigeria. Through a combination of qualitative depth and quantitative evidence, I demonstrate that when purposefully applied, can do what medicine alone often cannot. Join me as I explore this evening the intersection of arts, sector, and care, where healing begins not with diagnosis, but with dialogue. Not with silence, but with song. What I'm saying earlier is that in this aspect, we want to see how we can treat people, not on the one that person gets to hospital, but through the power of God. Not only in science, but through the rhythmic nature of sound to provide solutions. In my study, I tried to examine the background of trauma among Nigerian youth. I also examined socio-economic instability, communal violence, and cultural pressures. These are the things that we see that actually lead to several traumatized issues in society. In this study, we also try to examine conventional intervention in terms of chemotherapy, in terms of radiotherapy, in terms of medication, and their limited impacts. And also in this study, in the background, I try to look to establish culturally grounded and community-based solutions through theater performance. The statement of the problem of this work, I'm trying to investigate mental health practices, inaccessible, stigmatized, and underfunded. I also try to see youth trauma, how the youth that were traumatized have been neglected and untreated. In this study, I also try to investigate clinical methods or models, and also the urgent need for alternative healing practices beyond medication. Research objectives: to evaluate theater therapy's efficiency in trauma recovery, to examine social and emotional transformation in youth participants, to assess scalability, sustainability, and cultural fit as well as to promote theater as public health intervention. And that is the thrust of this study. I want to promote theater as public health intervention beyond entertainment, beyond education, but as a therapy for everybody in the country. Especially in Southwestern Nigeria. It will bring distributed of this. The study will bridge out and empower youth as agents of their own. The study will also provide medical services on community-based solutions. And as well, the study will definitely fill the gap, the critical gap in mental health research, not only in Southwestern Nigeria, but in Nigeria totality. The methodology used, although the work is in progress, but the methodology adopted to interpret this work, I engage the use of qualitative and quantitative methods between the age of 15 to 30 in selected community in Southwestern Nigeria.
4 minutes more. 4 minutes.
Yes, sir. I'm already in the findings. The findings, we found out in this study that music, dance, and storytelling aid cultural reconnection. We also discovered in this study that safe space for narrative transformation of trauma, increased emotional expression, and resilience. We also discovered that improved self-confidence and social bonding can be achieved through the use of theater as a therapy. In conclusion, as we draw this conversation to a close, one truth becomes clear. Healing is not one size fits all. Healing is not academic. Healing is not one directional movement. For many Nigerian youth, trauma runs deeper than the reach of peace or purpose. It is lived in the body, embedded in language, down through generations, and often silenced by stigma. What we have explored today is a radically different path. A path rooted in reading, a path rooted in movement, a path rooted in action, a path rooted in dancing, memory, and meaning. Theater therapy invites young people not just to recollect their thoughts, but to reclaim their narrative. It turns pain into performance. That's another thing. If you use theater therapy, it turns pain. What you think is sharp, what you think you're not comfortable with, we turn it to performance. We turn isolation into connection and silence into song. It is on this note, this study that theater therapy is not only a curative act, it is a cultural resonance, socially empowering, and emotionally transformative tool that can and should be recognized as a legitimate form of public mental intervention in Nigeria and beyond. Thank you for this opportunity.
Thank you all for your patience. I know that online presentation can be somehow, if things don't go really well with the technology, but we're happy that all the presenters were able to provide communication. And then the next thing we do is try to get into questions. I can see hands. I see you. So I'm going to count. 1, 2, 3, 4, 5, 6, 7. So we are going to go today. But someone was here in the audience and left. So he gave me some questions to read out. So I'm going to read those first and then start taking additional questions. So the first question went to Basira, and he's asking whether the diseases that you talked about, whether they are localized, in the Yoruba community, So the sense is that these diseases, are all over, like different ethnic communities. So that the way it's been presented sort of suggests that peculiar, that's peculiarity, is the same frontal to how you explain your work or something. So you want to respond to that. They kindly note it. The second one was Sandra, and it's asking specifically why the sample size is not broad and why for elderly people it's not at 4, especially because older people in this view are used to taking traditional medicine more. So he likes your clarification on that. So, but you don't have to respond now. We have more questions coming from the audience, so we start from here.
Thank you, Shiraz, for your presentation. I think
Is everyone online? Can you hear her?
Okay, thank you, Shiraz, for your presentation.
I'm here.
Interesting, and I think it centers around health promoting practices, public health, and among the Yorubas. But my question, the first question I will have had is related to the first question you asked. So I don't think I need to waste our time. But second, I think I would like you to you maybe just 1 to 2 sentences clarify your methodology. Thank you. Then to the woman, the woman. Yes, it's interesting. I think your presentation is interesting, but I'm sorry to use this word. It looks to me more like a motivational research because I have issue with. I wasn't following up with the methodology. So maybe you can also clarify then what is new in this research. That is what. Then the third person and the last comment I want to make is about the woman working on online presentation on urban alternative medicine and Sandra. And I don't know, maybe because I'm an anthropologist, I have issue with our methodology. For me, such studies should not be quantified. You cannot quantify issues that measures reality that way. If it has been mixed method, I think maybe we can begin to look at what mixed method and everything they have used. So I think we really need to look, the presenter really need to look into that methodology. I am not comfortable with it, and well, that is my opinion. But I think if she had applied ethnography, it would have given us better insight and deeper insight, given us what is new in this that you are presenting, and we can begin to look at the methodology gaps, the theoretical gap, and and some other things like that. But right now, the way it is, from what you have presented to us, I don't think personally I'm able to pick the real gap you are trying to put up with us. Thank you.
Thank you. Okay, it's not a clarification. I think please the use of motivational research, it should be taken back. Basically, it does not support. I
apologize if I listen. Or maybe I may have a better word for now.
It's not.
I'm just not offended.
No.
Not offended.
I think it's Professor, I didn't know what is manning up for. Well, thank you very much. My name is Igwa, and I want to really, first of all, commend the presenters for the presentation. I like the fact that we are trying to merge social sciences and the science and the humanities, the sciences, something that we need to explore more, and I really want to commend the effort for doing that. Now, I think I got in where Bashira was presenting. I don't know if there was a first presenter, but what was the one I saw? I met. And I'm a Yoruba studies scholar. So your research is very interesting to me, but I would like to know if your methodology includes the use of orature, because you cannot understand Yoruba culture and Yoruba spirituality and religion and tradition without engaging the orature. Especially when you talk about deities, because you're talking about Shokono. For you to really understand what this what they represent when it comes to merge with health sciences, medicine, and all kinds of sciences, you have to engage the orature. It may be difficult, but it has to be done, because I'm not sure, like I said, I didn't see when I came in, I don't know if you have presented something about if your methodology included that, but when I came in, I didn't see it in your presentation, so I wanted to suggest that you consider, and I was going to say also that your time to try to maybe consider bringing the tradition first because traditional came before the modernity, right? We kind of compare medical and because the tradition was already existing before the Western came, right? So you are comparing what came after with what had already existed, right? And Shokono, it's a lot of maybe at some points, but there are things that you are saying that I'm like, oh, no. Like for example, Olode, Shokono is Olode, Shokono is they are engaged that they kind of have mixed up in the presentation that I'm like, okay, Tutu is different. Ogunle Tutu. Yes. I said Ogunle Tutu, not Tutu. Well, so what do you use Ogunle Tutu for? Ogunle Tutu for precaution of misuse and some other well, yeah, no, you're presenting it. So I didn't say look in it. So you know, I'm trying to forget. So I was going to say, and then for well, I was going to commend you for even trying to do this study on men's health, because when we talk about gender studies, it's always about women. And I'm like, and it's so fine. You know, I mean, there are lots of the gender is very long now, but in this context, our context is mostly two, either the male or the female. We're always focused on the female. So I think it's very commendable that you are exploring this very, very underexplored area of humanity. One, two, I think you should there. I think your research will benefit a lot from ethnography. To benefit a lot from it because the things you are stating, there are things that we need to see. And I should tell you, I mean, we talk all the time. So I want to see you after and we discuss how you can bring about storytelling, how storytelling can really work for you. Because these are experiences of people. And when we are doing academic work, we always feel that we are removing ourselves from the society and you are trying to force us to back into it. So I think that is commendable, but you have to say clearly what your methodology is, and I think you will benefit a lot from that. No, but thank you.
Thank you. Thank you, sir. Okay. Yeah. So, just in accordance to what the previous question yes, now let me put it out. I've raised the house. One house, please. For me, I think it starts from the way the topic was coined. And if you look at the topic, the intersection of medical and traditional precautions on the Yoruba communicable, it makes it look as if this communicable is peculiar on the Yoruba community. So you might have to work to show that you are looking at the Yoruba traditional precautional methods, on all of these NCDs or how NCDs are being treated among the Yoruba. Then to our man of woman, thank you once again. Just as Father have said, thank you so much. I just want to raise the issue of ethics. In the course of your presentation, you mentioned something which should not be one of sort of Seneca, 7 children. If I don't, I can Google the Seneca now and start stigmatizing that we had you in Lagos, we have 7 children and all of those stories. So there could be pseudo names that can be, and that is basically that. Actually, online presenter, I think Sandra, first I want to say thank you because the study was about my community. I'm from Agbo, but I'm a lost son of Agbo. So when I saw that title, I was like, let me come and listen to what's happening in my community. I've only been there once. So, but now the issue is this. As interesting as the subject matter will have been, along the line, I missed it in some way. First, with the sample size, even if you are going to use quantitative method, 30 definitely is too small. And it became problematic when we began to see that over 70% of your respondents have tertiary education. It shows that there was some skewness in your selection criteria and the whole selection process of the study. And then again in the presentation, we were talking about practices in Agbo, in Nika, and you're talking about Agbo. I don't understand the language so well, but I'm very sure there must be an indigenous name to describe Agbo. And then you should also come up to tell us what type of, if a Yoruba person is to talk about Agbo now, I'm very sure they're going to list out 20, 25 different ago for different ailments. But just give us ago, which I don't think is good enough. And to the last presenter, yes, theater therapy is now good. Thank you for providing that alternative. But my first concern would be that as good as it looks on the surface, I doubt, I'm here to go to the field, that that approach will suffice for all sorts of mental illness. Can work with depression, anxiety, PTSD. But when you begin to talk of mental disorders like schizophrenia, bipolar disorder, and so many other major mental health issues, I need to be convinced that theater therapy will work. And again, finally, because I'm a political scientist, but into public health policy and all of that, one major issue that we found out in public health is the issue of coverage, and access. So if this is an alternative to whatever process that we have, what would be the level of access that people that need it would have to this therapy? Because that's even basic modern drugs are not even covered on our health insurance, not to now talk of drama or theater therapy as an alternative to address some of these issues. So once again, thank you.
My question was because I think you can, it's just a suggestion from my own personal actually. What I understand about research is to identify a problem and then to recommend or private to prefer solution to that problem. You have actually told us about the intersection. I think it's better for you to also have it in such a way, or in such in a way of recommendation, where traditional medicine can also complement orthodox, where orthodox medicine can complement traditional medicine. So the second question goes to the second presenter. The presentation was really interesting, but to me, I don't know. I want to ask you, I don't know if you also consider gender change in terms of responsibility. Because when you were actually presenting, I saw you giving some examples. In my observation and in the course of my interaction with other fellow men, I discovered that most responsible So my interaction with them, they often confirm that most responsibilities, most men's responsibilities then has almost been shifted on women. Not even shared. Not shared. But you can also consider that so that it should seem that if you are being mental. So you can look for a way to also balance it because I want to be there.
So we go start from take one question from the back. Please let's gather all the questions. I don't think we're going to go for a second round. So I thought you were raising up your
hand. Thank you, presenter. Just three questions. I didn't get why you choose your message. And then for the second presenter, Prof, I want to tell you the professor there. I want to she from I understood your concerns in the paper, and like the other my brother mentioned that the needs to advise the respondents. So I think she's a younger colleague and she's still behind in history discipline. There is a way we verify facts. If she would have presented this among historians, they may feel like if she's not naming things, they may feel like it's fabricated. So, but in this instance, we will take into consideration the journal. If it's a chronological journal, we will manage the paper towards that angle. If it's a historical journal, we will do it according to our way. So that's what.
Thank you. We like when the supervisors to show up. So we take more questions from here. But I'll go through this. That's one thing.
Good afternoon, everyone. Good afternoon. Thank you for your presentation. But I have a question to Bashirat. When you were mentioning the traditional Yoruba precautions, I was expecting to hear some precautions. Now you said cleanliness, isolation, avoidance. I don't think that's Yoruba precaution. Cleanliness has even been in the Bible, even isolation, even leprosy. They've been in the Bible and it has existed. You only mention the spirits, one or something spirit. And I was expecting to see more of that. And I did not see that. Maybe you should verify me on that, but I don't think these are usual precautions. These are general. Then to Adako, they've already said what I wanted to say, the name. But the second thing I wanted to add, the interview, the key people, was there any male gender?
Yes, the second person that said
Because why my question is sometimes we try to deliver that don't want to be delivered. When you say man up and the public better health, do they want to be delivered actually or they even want to they don't find out that was why because I probably the ethnographic maybe a focus discussion with them to actually know what is
Thank you very much. Thank you very much. I think these are important observations. You should try to take note of them. At least moving forward, I think it will be really, really productive because for FGD, give you a lot of very reflective responses, in this community of men. A lot of times, even when we do research among men and mental health issues is deeply individualized, and that can give a lot of voices. Yeah. Exactly. Actually came together and all of that. Even by bringing them together. Even by bringing them together, you are doing some therapy.
and they'll be able to mind up.
So we'll take a question here and then.
So we have one now.
No, yeah, you. I thought. Yes. You and then.
Oh, because you are.
I'm not joking.
It's okay, by something like that, so I'm going to do anyway. I just want to ask there is like she had the period, because 23 years of, policies there and there, I guess we should move back for a paper. I want to believe so. That's my own point of view, though, because I want to believe these things can be broken down because we have a lot of policies, a lot of recommendations, a lot of things to achieve. So I want to believe it can be sectionalized. I don't know why I know doing it, or maybe I'll go with more papers on that instead of jamming everything into, I don't know, proper analysis. Yeah, exactly, exactly. So that's my own. Then the last presenter, theater therapy. I don't know whether you have ever come across the work of Professor Lightning Nasir. I guess that's what he used for a thing. Maybe if you had done that, you would have been able to help, define which aspect of mental, mental health or psycho. I don't know what you're actually working on. Then methodologies are too. Before I forget. So, sir, those are my two something. Just try to see his work and see how we can use it to guide your own work.
Thank you very much, sir. So we take the next comments and then the final one. Sir,
my own is no more. I am neither secretarian or anything. I'm a colleague. But God, I believe only in God. I don't believe in Jesus. What is God? If you say something about manual, I want to ask a question. My questions are very simple. You might throw up some other discussion. Whose fault is it? Mental health. Is it the man's fault? Is it the society's fault? Is it the whole fault? Then you believe what they call destiny. Or you are born, or you are conceived. I know you. And they said this world is a stage. Everybody came here as an actor. We are acting. Are you not sure that that is the role? Give it to that person to put in.
So we'll take the final comment. Please, one house. Let's take the final comment and we'll give a few seconds to the presenters to say a thing or two.
Yes. My comment is to the Baptist mission presenter. I'm sorry, I don't recall your name. But my question is, first, like, what do you think about the competition between several missions in Yoruba land during this particular period? Second is, what do you think about the public-private relationship between missions and colonial states? Are there point of tension? Are there point of, collaborations? Then third is also, what do you think about the social changes? The First World War, the Second World War, how did that actually shape missions, responsibility and responses? And also like the question of conversion itself, it's very problematic. And lots of scholars have actually talked about how are you thinking about conversion in terms of, the Baptist mission themselves? Are Africans taking advantage of conversion to escape brutal Yoruba chiefs during this period? Or are they just, seeking it out to kind of like, for curing or for healing or what have you? So I think,
Thank you very much. So we don't have time, but please take 30 seconds, 30 to 45 seconds to respond. If other things, there's going to be a lot of discussion. We have time here after this session. So please, Bashir, go.
Thank you very much. So the first comment and the first so documentation method and interview method were used for the production of data for the study. Documentation were used by consulting different existing different that is talking about communicable disease and some other measures. Then interview method was used to by consulting all the Yoruba traditional health practitioners to know how they will do this. They've been also doing different types of precautions, what they are using, all those things to know them. That was how we came up with that. Then talking about the what is it called? Prevalence of the disease. Okay, I should do those one.
Yes, just one response to the audience. That's all. We are not going to. You will talk. Let's keep this simple. Almost done. You can have the conversation after. She's here. She's happy to talk to you. Yeah. So please.
Thank you everyone for your showing and correction. I'll put into completion another lot to cover about. And also for the other one on, I hope just based on fact checking. The effect on fact checking on those mental health. I was asking me what's meeting I'm trying to see. Because every time you talk about patriarchy and women oppressing women from that angle, but we really talked about what patriarchy and that are fact to me. So that's what my work is.
Thank you very much.
Thank you. All observational.
Please, 1 hour. We're almost done.
The issue of periodization is studied in Yoruba land, the whole of Yoruba land. Baptist Mission Medical Services started in 1907. The whole of Yoruba land. And then the termination of that study is trying to explore the spaces cases of changes. At the time it started solely as Baptist mission issue. At the time it was a collaboration. At the time the state took over. Now talking about the analysis you mentioned now, so I can now look into that area which I highlighted in the course of this whole time.
All right. Thank you, Honorable. Musili, final word, please.
Yes, sir. Thank you very much. I sincerely appreciate the opportunity, but I just want to quickly pass a comment on the coverage of theater. Theater is everywhere. And that is the reason why that one medication, one prescription cannot solve our problem. If in China and other parts of the world, they are using acupuncture as another means of healing people, we can also engage in theater to heal people. And that is my submission on that. Thank you very much.
Sandra, final words.
Okay, the word Agbo was intermittently used with traditional medicine, which simply portrays the context which I'm talking about. These medicine that are sold by these local street vendors. That is why I use the word Agbo. And also the small size sample has to do with the respondent not responding, especially the aged people. It wasn't easy getting information from these persons. Hence the small size of the sample, but hopefully I will improve on that.
Okay, so once again, I would like to say thank you to everyone. Please let's thank you to presenters, pastors, Olufemi, and then sorry. Sandra, I will see you. It's been really welcome to listen to everyone. It's got a bit charged towards the end, but I'm sure that people who are here are open to having conversations around this issue. That's why they are here, and they are still going to be here for the next 2 days, so we can meet up and talk about these issues. So, but let's not forget. Public health humanities. We are trying to put humanities at the internet of health, public health, healing, and care more generally. We have another session coming up just at 5:30 in room B412. So please endeavor to join us. We have papers to present, myself and Sharat and a couple of other people on that panel. Please join us if you can. We really love to have you here. But with that, say thank you. Thank you to those online. Really appreciate your time, and thanks to the.
Thank you.
Thank you, sir. Thank you, sir.